All right. We are recording. We are good.
All right. Welcome to our Nursing 418 OB Putting It All Together case study discussion. Today, our group, Dee Dee, Soleil, and I, Katie, will be discussing the case of Maria, a 24-year-old Gravida 1 Para 0 at 34 weeks with chronic hypertension, suspected infection, psychosocial concerns, and limited prenatal care.
Did we lose her?
Dee Dee? I think she's frozen.
I think she is.
Sorry, my computer is very laggy right now.
I know.
We will walk through the case assessments, clinical judgment, and evidence-based interventions.
Throughout the presentation, we will also be providing scholarly resources and also resources from the CSP library.
Can you guys hear me?
Yeah.
I think she was still talking and we didn't hear her. Dee Dee, are you talking?
Oh no.
Oh no.
We were doing so good.
We got bloopers.
Yay! Well,
Dee Dee, you're frozen.
wait, no, there she is. She's back.
Can you hear me now?
I can hear you now.
Oh my goodness, what timing.
Mm-hmm.
All right.
Okay, you want to start over?
Yes.
All right.
Okay. Welcome to our Nursing 418 OB Putting It All Together case study discussion. Today, our group, Dee Dee, Soleil, and I, Katie, will be discussing the case of Maria, a 24-year-old Gravida 1 Para 0 at 34 weeks with chronic hypertension, suspected infection, psychosocial concerns, and limited prenatal care.
We'll walk through the case study and then discuss each of the 15 prompts, examining our assessment, clinical judgment, and evidence-based interventions.
Throughout the presentation, we will also use scholarly and CSP library resources alongside case studies from our course materials.
So our case study starts with we are the nurses practicing in an urban hospital, and we have a 24-year-old Gravida 1 Para 0 woman named Maria who presents to the hospital that we're working at. She has 34 weeks of gestation and having intermittent pelvic pain, which she believes are contractions. Her 39-year-old boyfriend accompanies Maria. She currently lives in a mobile home park with her partner and his 7-year-old daughter. She states she was strongly considering giving up the baby for adoption because of financial and other reasons. She reports she has not had any prenatal care, but has been taking care of herself. She quit smoking and drinking and is eating daily. She currently is not working, as she recently lost her retail job, and states that sometimes learning new things is really hard and things have already been so stressful. She relies heavily on her partner for support. She states she is not close to her family, as there is a history of significant physical and emotional abuse with her mom and stepdad. Her physical presentation, she has significant abdominal pain, and upon further assessment, she reveals that her pain extends to her left flank. Maria also feels warm to the touch and indicates she has had difficulty voiding recently. Does have a history of recurrent UTIs, but reports they typically do not feel like this. As you are assessing Maria, you see that she is very pale and has notable bruising on her arms, back, and legs. Maria is quiet and does not offer information unless asked directly. Her significant other has stayed right next to her since being admitted. Maria's initial vital signs reveal a blood pressure of 188 over 101. She reports that she has had high blood pressure for a few years and has been taking lisinopril. She stopped taking lisinopril when she found out she was pregnant because her partner said it was not safe for the baby. She also stopped taking her antidepressant at the same time. She has no other underlying health conditions. An ultrasound is ordered for Maria, which confirms a gestation of about 34 weeks, reveals low amniotic fluid and a closed and long cervix. Maria's labs reveal her liver functions to be within normal limits. Her urine analysis reveals no proteinuria, but is positive for both white blood cells and red blood cells. She has a culture and sensitivity being sent. So some screenings that we're going to look at for Maria. The first one would be a hypertensive disorder screening, which would include serial blood pressure readings, a CBC, a CMP, renal function, and close maternal fetal monitoring. Chronic hypertension combined with infection increases the risk of preeclampsia progression per Aruna and Dakshinamurthy 2025 and Yan 2018.
Maria will also need to get a UTI and pyelonephritis screening. These will include a urine culture and sensitivity. UTIs are strongly associated with preeclampsia, preterm labor, and maternal morbidity. Maria may also have sepsis, and we will need to get blood cultures per Stormy 2019.
Given her bruising, her guarded behavior, and partner presence, intimate partner violence, IPV, screening is essential. USPSTF recommends universal IPV screening in pregnancy according to Silverstein 2024. We must also evaluate for perinatal depression and anxiety, as Maria used to be on antidepressants. And IPV and antidepressant discontinuation evaluate mental health risk. With more screens that we could be looking at, in our case study, it talked about her getting an ultrasound. I think during that ultrasound, we would also be looking at anything else going on in the pelvis, or potentially looking at the kidneys as well to make sure she doesn't have a kidney stone. And then looking at labs, we don't always want to assume that it's necessarily partner violence right off the bat. She does have a 7-year-old at home, asking questions on whether she plays a lot physically with a 7-year-old. The case study also mentioned she's very pale. So looking at all those labs and making sure she's not anemic, or, making sure she's eating properly, are all things that we want to take into account before automatically jumping to partner violence. But the IPV screening is definitely essential. We could also look at STDs as something that might be causing some of her pelvic pain. So getting the partner out of the room would be something that would be beneficial for her. I know at my job, if I work in the ER, so if we have to have a partner leave and they're not willing to leave, we end up having to come up with little lies like the front desk needs to talk to them about insurance or something like that to get them out of the room just for a few minutes so that we can talk to the other person in the room.
Some immediate problems that Maria has. Our first major concern for her is going to be her hypertension. It appears as though it is severe and it's chronic. As she stated, she has had high blood pressure in the past and was taking lisinopril. She did state that she stopped taking it without a provider recommending it or having the oversight of that provider. This places Maria at a very high risk for stroke, hypertensive crisis, which it appears she's already in, and placental complications per Mayo Clinic 2020.
So the second issue is the suspected UTI or pyelonephritis, given her flank pain, her fever, and abnormal urinalysis. These infections increase the risk of preeclampsia and preterm birth, according to Jan. Along with that, like I was talking in the other slide, but looking at an ultrasound, since we can't send her to CT, to just make sure she doesn't have kidney stones, which happen a lot in pregnancies, especially stressful ones. And then because those can infect, your ureter tubes if one gets stuck. And then also just double checking that she's not meeting sepsis criteria.
Additionally, the bruising, the quiet effect, and her partner hovering could possibly suggest that she has intimate partner violence. It is also stated the bruisings on her arms and her legs. So it's kind of in areas where she might be grabbed or handled roughly. If this is occurring, it increases her risk of inadequate prenatal care, maternal mental health decline, and adverse fetal outcomes per Agrawal 2023. So like we said before, we want to try and separate them. That way we can ask and make sure that she feels safe. This way we can kind of get like a better feel of what's really going on. We can ask how the bruising occurred and determine if there might be an actual risk of abuse.
So prioritization for her, our highest priority is maternal stabilization. So especially controlling her blood pressure to prevent acute hypertensive complications, according to Mayo Clinic 2020. Right now, she kind of falls into that hypertensive urgency area. And then we'd also want to be checking for like additional symptoms of her blood pressure being so high. So headache, shortness of breath, any vision changes, because those will put her at risk for stroke, and really just getting a clear picture on how long those symptoms have been going on.
Like before, I think we said it already, we'll assess for the sepsis criteria. This will address infection, which if that is the case, we need to start interventions immediately to promote outcomes. UTIs double or triple the risk of preeclampsia and can cause rapid deterioration if untreated, per Aruna and Dakshinamurthy 2025. We also need to rule out other complications and complete a thorough head-to-toe assessment, looking for edema or kidney damage by her labs, changes in cardiac output.
In the case study, it talks about how Maria has a quiet affect and she's not really answering questions unless she's directly asked. For ensuring that Maria's physical safety is prioritized here, we need to also make sure that we're trying to build a rapport with her. Try and get her to trust us while we're getting the boyfriend out of the room. That way we can get a more accurate presentation of what her home life is like if she is experiencing intimate partner violence. Routine screenings facilitate early intervention and better maternal outcomes per Silverstein 2024 and Denisa 2020.
So her current conditions can impact the duration of her pregnancy. Her hypertension alone increases the risk of medically indicated early delivery, as stated by the Mayo Clinic 2020. If unmanaged, this could eventually result into preeclampsia, eclampsia, and a higher risk of placental abruption per the CDC 2025. This could result in fetal and maternal harm and eventually lead to demise.
As we stated before, Maria is possible for having a UTI or pyelonephritis. This will increase risk for preterm labor and adverse fetal outcomes per Jan 2018. As Katie stated before, we need to get the ultrasound to rule out that there aren't kidney stones present. Kidney stones are more frequent during stressful pregnancies, which Maria herself has already said she's very stressed out. This can put her at a higher risk for sepsis or other complications. Um, the ultrasound is going to be our safest method for checking these, as it will ensure the fetus's safety.
So, IPV exposure independently correlates with preterm birth due to increased stress, anxiety, and inadequate prenatal care patterns, according to Roman 2021, which we can already see, even though we don't necessarily know for sure she is having partner violence, but we know that she hasn't sought prenatal care. She's stated she has a lot of increased stress and anxiety at home. So we're already seeing those things in Maria. So for fetal impact, the fetus is at risk for low birth weight and intrauterine growth restriction due to Maria's hypertension, according to Agarwal 2023. This will also be checked when she gets an ultrasound, checking on baby and herself. So making sure baby is growing and where the baby should be at the 34-week mark, or if the baby is low in their growth, the ultrasound will be able to tell the doctors everything they need to know from that.
Another complication that can affect the fetus is oligohydramnios. Also increases the risk of cord compression, meconium aspiration syndrome, and fetal distress, per one of our case studies, 2025. Cord compression results in hypoxia to the baby and may significantly impact the well-being. It increases poor antepartum outcomes in development. It increases the risk of infection and poor development, like poor lung development and limb development, which greatly increase the risk of fetal demise.
Intimate partner violence can contribute to preterm delivery, poor fetal oxygenation, and developmental concerns, which Dee Dee already went over. The placenta can be directly harmed in cases of IPV through either the stress hormone cortisol being released, or physical violence, causing the placenta to detach or become restricted. Speaking of cortisol, if mom's cortisol levels are high, this can also impact the fetus's brain development and could cause developmental delays later on in life, per Roman Galvez 2021.
So as Maria's nurses, further assessments that we should complete would be a pregnancy-induced hypertension panel. And this would include like a CBC, liver function, kidney function, and placental function test, per the Preeclampsia Foundation 2025. We'd want to do any repeat labs and some blood pressure readings. Assess for peripheral extremity edema, headaches, or vision changes, which would be associated with preeclampsia, and then ask Maria about any fetal movement or activity, if there's been any abnormal bleeding or bruising, or any changes or new discharge in the vaginal area that might lead us to some other complications that could occur.
We also need to get the full urinary evaluation via urine culture and potentially blood cultures, as we are suspecting that she might be septic, because we need to verify that there is an infection present, per Stormy 2019. We can dip the urine at bedside, and if that comes back saying that white blood cells are present, we could potentially contact the provider to explain what's going on and get orders for a broad spectrum antibiotic before we actually get the full culture back. And then we also should monitor Maria's input and intake and output pretty strictly, because we need to make sure that her kidneys are filtering and that she has the appropriate output for her body weight. To do this, we might need to insert a Foley catheter just to have a more accurate measurement.
So another assessment that we need to do that we've already kind of talked about, but is to do the IPV interview for the partner violence. But this is essential that it be a private interview, as partner violence frequently goes underreported without confidential screenings, according to Silverstein 2024. And then mental health screening should occur due to the high risk in partner violence affected pregnancies, according to Diaz 2025. Both of these are things that we kind of touched on already, needing to happen, but especially since she quit taking her antidepressant, and she has this potential for partner violence, it's really important to get accurate information and for Maria to know that she's safe giving us that information. So let's talk about our care planning goals. So for the first goal for Maria, goal number 1 is Maria will maintain safe blood pressure values without signs of end organ damage before discharge from the hospital, as she will likely be admitted to the hospital. Mayo Clinic 2020.
Goal number 2 would be Maria will show decreased urinary symptoms and improving labs following antibiotic therapy before discharge. With this goal, I think we would also focus on her output and ensuring that her kidney functions stay at an appropriate level.
The third goal would be to ensure that Maria feels safe and supported. We need to complete the IPV screen and ensure a safety plan is in place, and that Maria can receive the resources that she might need prior to discharge. Some education topics that we as Maria's nurses should bring up with her. The first one I would say would be her hypertension dangers. She has a history of high blood pressure, as she's already told us, but we need to make sure that Maria understands that some of these dangers include stroke and placental complications per Mayo Clinic 2020. We as nurses need to make sure that Maria understands what the placenta is and what it does. We should also teach her the signs to look out for in case of stroke, specifically fast. Having her demonstrate for us, smiling, putting her arms out, knowing what slurred speech, all of these are symptoms of stroke. And that lastly, she needs to note the time that these start and that it's in a medical emergency and she needs to contact 911 and get straight to the hospital. We should also include some preeclampsia education in here, including a headache that won't go away even though you're taking medication, and your face appears to swell like overnight. But swelling in the legs and the feet, sometimes the hands, those are all normal, but specifically that facial swelling, again, these are medical emergencies and she needs to go and get straight to the hospital. Otherwise, she can put herself and her baby at risk.
So another education topic with Maria is making sure she understands the importance of treating the UTI, and if it happens again in the future, to make sure she gets prompt treatment. Treatment of the UTI dramatically, because without it, it can dramatically increase obstetric complications, according to Aruna and Dashkamurthy 2025. UTIs left untreated can turn into kidney infections, even without a kidney stone present. And then that can quickly lead to sepsis if left untreated, which is a whole body inflammatory response to the infection. And it's much more serious and it can be life-threatening to just a normal person, but it's even more life-threatening to both mom and baby when you're pregnant.
Our last education topic includes safety resources like safety planning for intimate partner violence. which this would include screening for and making sure it's confidential and evidence-based per Silverstein 2024. Safety planning can include having a backup cell phone, changing locks or security cameras once the person at risk is removed from the abuser. We also want to help create a plan of care where they can find safety. We can do this by connecting them to local communities or help centers, organizations, caseworkers, social workers. We want to help the patient identify people that she can fall back on for support, both physically and emotionally. Educate on the signs of intimate partner violence like seclusion, physical and emotional abuse, and then partners needing to have control over situations. For Maria, you can kind of see the seclusion and her following his commands for not taking her blood pressure medication. Other things that we might look for mental health warning signs is like frequent crying, increase in anxiety, a lack of personal hygiene, and just support from people around them. Interdisciplinary teams that should be included for Maria would be a maternal fetal medicine provider who specializes in high-risk pregnancies such as Maria's. This doctor would be able to treat Maria for hypertension and more in-depth fetal surveillance per the Mayo Clinic 2020. This type of provider can help manage Maria's hypertension that occurred prior to her pregnancies and the risk they impose now. They can also help improve maternal and fetal outcomes with this high-risk pregnancy by management of polynephritis, her hypertension, and possible preterm delivery related to her risk.
A social worker is going to be essential in Maria's case, as they can help us create a safety plan for Maria if there is IPV present, and can also give her resources per Tahinsa 2020. Social workers can help Maria find clinics that will support low-income people, such as herself. A lot of these clinics can offer prenatal and also the immediate pediatric care for the baby at either low cost or for free. Some of them even have payment plans. As Maria said, that she doesn't have any health insurance. Maria is also going to need resources for once the baby is born. The baby's going to need clothing, bottles, you name it. Social workers can help Maria find places to get these items for either free or at very low cost.
So IPV advocates and perinatal mental health providers are critical components of holistic care according to Diaz 2025. Making sure Maria has a way to access those resources without the boyfriend finding out is essential, so that when she is ready to leave that situation, she has those resources and can act on them. And making sure she is educated on the risk of postpartum depression being much higher in a patient who already suffers from depression. We would want to get her connected to a mental health provider and encourage her to go back on her depressant, and that there are safe options out there that you can take during pregnancy. And then last but not least, since she is high risk, just educate her on a NICU team and what that looks like in her pregnancy if she were to deliver early is really important. Also, knowing what hospital she should go to if she goes into preterm labor is really important. So, social determinants of health. So for Maria, one of the big things for her is financial instability and limited access to care are major barriers. So I think like using our interdisciplinary teams, so using the social worker, being able to get her connected to resources like we had talked about. Since she states she doesn't have current health insurance, I think having the social worker discuss with her the process of signing up for state assistance options, and then seeing what she can qualify for would take a huge stress relief off of Maria if she knew she had that in place. Also, I mean, just they provide other things like, food and formula for the baby once the baby's there, if she's not able to breastfeed. So I think that's relieving some of that financial burden would be a huge help for her.
The possibility of the intimate partner violence can also be a major social determinant of health, which widely impacts her care and her baby's care per AGWAR 2023. IPV places her at a risk of being unable to maintain a job, which she has already lost, and unable to obtain another one. This impacts her finances, which she relies on her boyfriend for basic care needs and socialization. IPV could impact prenatal care, as in Maria's case, she stopped taking her lisinopril and her antidepressant without medical consultation, which this could in fact result in a rebound hypertension and a risk of a mental health crisis. Having limited financial access places her at a risk for limited healthcare insurance and transportation, which may also affect her prenatal and antepartum care of Maria and her new baby.
Maria's history of trauma and her mental health strain also place her at a disproportionate risk for adverse outcomes per Roman Galvez 2021. Some of these adverse outcomes could be impaired prenatal attachment, heightened susceptibility to postpartum depression and anxiety, difficulty with labor pain management, reduced engagement in her care, which we're already kind of seeing here at the beginning, and an increase for OB complications. Some of the contributing factors on how Maria got here. Number one would be her hypertension and the infection. These directly contributed to her acute symptoms per Jan 2018. These were driven by uncontrolled vasoconstriction, elevated systemic pressures, and inflammatory stress. These altogether combine to increase her risk for preeclampsia, end organ strain, worsening flank and abdominal pain, and potential placental dysfunction. An untreated UTI could further amplify her hypertensive instability and could progress her towards pyelonephritis, which we've already suggested as being a possible thing that brought her in today. All of these together could explain her fever, her difficulty voiding, and the escalating discomfort that she's experiencing.
Another contributing factor for Maria is her lack of prenatal care exacerbates undiagnosed complications. Maria discontinued her antidepressant and her blood pressure medication, which now puts her at a much higher risk of complications in this current pregnancy.
Her intimate partner violence and psychosocial stress increase risk of poor self-management and psychological instability, per Diaz-Ogalar 2025. The lack of social, mental, and financial support increases stress, which can increase the complications of pregnancy and contribute to her higher elevation of blood pressure.
So some evidence-based physical interventions that we can do. So first, we would want to administer a pregnancy-safe antihypertensive and IV fluids per provider order according to Mayo Clinic 2020. Depending on whether or not Maria is meeting that sepsis protocol, if she is, we would want to implement those quickly and implement that whole protocol as quickly as possible, and get her started on antibiotic therapy as well.
Like we just said, treat suspected infection with appropriate antibiotics and monitor labs. So we could also monitor her lactate encourage fluid intake and proper fluid electrolyte balance, monitor for complications like increased hypertension symptoms or organ damage as well.
We'll also need to initiate continuous fetal monitoring due to the oligohydramnios and the elevated fetal risk per our case study this year. The reduced amniotic fluid can limit the fetus's protective environment. This will increase the fetus's chance of cord compression and heightens the vulnerability to hypoxia. Continuous monitoring will allow us rapid detection of any late decelerations, variability changes, and emerging distress that the fetus may be experiencing.
Just to go back, I think some other interventions we could do would be apply oxygen as well, so that we make sure the baby and mother are getting enough oxygen perfusion and ventilation, and then to, oh gosh, I just lost it. What was the other one? I lost it. Go ahead, go forward. Sorry. Some psychosocial interventions would to perform the screening and connect Maria to advocacy services per DSEN 2020. We want to ensure that the patient feels safe, comfortable, and confident in her ability to provide safety after the delivery of her baby. And as nurses, we also want to use the therapeutic communication and touch so that they feel safe and feel like they can talk to us about any complications that they might be having.
We also need to provide Maria mental health referrals and counseling support per Diaz-Ogalar 2025. Maria abruptly stopped her antidepressants and she has a possible exposure to IPV. She has a history of childhood trauma and current high stress environment. All of these together place her at a significant risk for perinatal depression, anxiety, and could even lead to suicidal ideation in some cases. Any early interventions we can provide for her can help her stabilize and ensure she has adequate coping. She has a safety plan in place and can improve both the maternal and fetal outcomes by reducing the cumulative stress that drives the psychological deterioration.
We kind of already touched on like the mental health referral and getting her those services. But one of the biggest things that we want to do is use trauma-informed communications and build rapport to enhance safety and trust. For a patient like Maria, who presents with physical bruising, a history of abuse, a controlling partner at the bedside, and significant psychosocial stress, trauma-informed communication is really essential. So this approach begins with recognizing that Maria's behaviors, like her quiet speech, her guardedness, minimal eye contact, reluctantness to disclose information, may be adaptive survival responses related to past or current trauma. As her nurses, our priority is to communicate in a way that reduces fear, promotes emotional safety, and empowers her during a vulnerable time. And we can do this by approaching every interaction with the core trauma-informed principles, which are safety, trustworthiness, choice, collaboration, and empowerment. For Maria, this means speaking calmly, using non-judgmental language, and allowing extra time for her to respond. Instead of pressuring her to share details, we validate her feelings and normalize the challenges she is facing. Simple statements such as, "You deserve to feel safe here," or "You are in control of what you choose to share," can begin restoring autonomy that may have been taken from her in her abusive relationship. Another essential component of trauma-informed care is creating private opportunities for disclosure. We talked about this a little bit earlier. Because her partner never leaves her side, Maria may fear retaliation if she speaks honestly. We can gently arrange moments to be alone With her, such as saying hospital policy requires a brief one-on-one assessment with every patient. This removes blame from her and prevents escalation from the partner, and then when alone, we avoid direct interrogation and instead use open-ended supportive prompts like, how are things at home for you? Do you feel safe with the people in your life? Is there anything you've been worried about that you haven't been able to say yet? Building that rapport also involves respecting her pace and respecting her choices. Many survivors choose not to disclose immediately. Whether she opens up or not, we reinforce that we are a safe place for her and the information she shares with us is confidential. We can provide the IPV information discreetly through brochures, slipped into discharge paperwork, or via coded handouts that do not draw attention from the partner. Because trauma affects cognition, memory, and decision making, we deliver education slowly in small segments, checking for understanding frequently. We avoid overwhelming her with medical terminology and supportive, validating language, such as, it makes sense you're feeling overwhelmed, you've been crying a lot on your own, or carrying a lot on your own. You're doing the best you can with what you've been given. Trauma-informed report also means inviting collaboration instead of dictating treatment. And ask questions like, what concerns you the most right now? What would help you feel more comfortable during your care today? Doing this shifts the power back to Maria and strengthens her trust and improving engagement in her care plan. And finally, trauma-informed communication recognizes that safety planning, not forced disclosure, is the goal. Even without confirming IPV, we can offer Maria choices, connect her with social workers, and provide supportive resources. And over time, these actions create a therapeutic environment where Maria feels heard, respected, and safe enough to seek help when she is ready. So some family-centered interventions. For this, we want to use shared decision-making to prioritize Maria's voice and autonomy. For patients like Maria, shared decision-making is not only best practice, but also a critical component of trauma-informed care. Patient-centered care, SDM, which is shared decision-making, helps restore control, dignity, and self-efficiency, all of which may have been compromised by trauma, coercion, or fear. With shared decision-making, the nurse intentionally shifts away from a directive or authoritative approach and instead partners with Maria. This includes providing information in a clear, supportive manner, exploring her concerns, and encouraging her to express preferences about her care. The goal is not simply to offer choices, but to empower her to see herself as an active, valued participant in every step of her treatment plan.
We also want to support safe family involvement only when it does not compromise maternal safety. So if we rule out that there is no abuse suspected, we should include her significant other into the plan of care and what interventions should be included and shouldn't be included, especially since he is the one that had the idea that the lisinopril and most likely her antidepressant were harmful to the child.
We also, as nurses, need to make sure that our care is coordinated across many disciplines so that we can provide a cohesive maternal fetal support. By involving the OB provider for the high-risk pregnancy management, L&D nursing for continuous assessment and monitoring, social work and IPV advocacy for safety planning and giving her resources. We should also include perinatal mental health services for making sure that Maria is stable psychologically, and then also case management to help her discharge and allow for follow-up coordination. The NICU team could also be involved in case that Maria does end up delivering early, because the baby is at risk for a lot of complications once they're born, like low birth weight, developmental delays. Their lungs might not be fully developed as well. Some outcomes that we want to see for Maria. Number one, we want to make sure that her blood pressure is stabilized and that her labs are improving. At the time that Maria presents to us, she is in a hypertensive crisis, and that is the first thing that we need to address.
Outcome number 2 is documentation of the IPV screening completion and safety plan follow through.
Outcome number 3 would be engagement with prenatal and mental health care for long-term wellness. Have the patient set up or identify 3 mental health care providers they can contact within the next week.
So that is it for our presentation. These interventions all address Maria's physical, psychosocial, and safety needs.
And they integrate both the nursing process and clinical judgment.
Thank you very much for listening to our case study discussion.
Thank you.
Thanks.
All right, guys, that's 43 minutes.
I was going to say like 40 something.
Yeah, I was like texting on like, we're at 30. We can wrap it.
Oh, sorry.
Oh,
I told you that was long.
Oh, you're fine.